Hello, everyone. Thank you so much for joining us here today. On behalf of the American Heart Association of Southeast Michigan, I just want to thank you all again for joining and taking the time to learn about high blood pressure. Thank you especially to Blue Cross Blue Shield of Michigan for helping to power this event. We are very fortunate to be partners with them for over 16 years. At the AHA, we know that hypertension and high blood pressure doesn't discriminate. Sadly, 1 in 2 adults in the city of Detroit live with hypertension or high blood pressure, which is the leading cause of cardiovascular diseases and stroke. We also know that your zip code can have a direct impact on the quality of healthcare and services that you receive. Today, in partnership with Blue Cross Blue Shield of Michigan, our expert panelists will shine a light on the silent killer, uncontrolled high blood pressure, through a discussion on the importance of creating health equity and inclusion within our communities and the work that is being done right here in Southeast Michigan to eliminate social determinants of health and combat heart disease and stroke, focusing on high blood pressure. But first, let's take a moment to watch a fun little video to shed a little light on some proper ways to check your high blood pressure, and then we'll get into our discussion. Just a quick housekeeping item, please feel free to type in the chat as you're hearing from some of our specialists or any questions that you have, because we will be having a Q&A after the panel discussion. But for now, we're going to go on to our little video. And, all right.
Get it, slip it, cuff it, check it. Talk to doctor now and share it. Get it, slip it, cuff it, check it. Talk to doctor now and share it. Gonna get it, gonna slip it, gonna cuff it. Check it, talk to doctor and share it. Gonna get it, gonna slip it, gonna cuff it. Check it, talk to doctor and share it.
Get it, slip it, cuff it, check it. High blood pressure silently affects millions of Americans. Staying on top of your blood pressure is as simple as these 4 easy steps. Self-monitoring is power. Visit manageyourbp.org to learn more.
And now it is my pleasure to introduce Dr. James Grant from Blue Cross Blue Shield, and he's going to share a few remarks. We're super excited to have him be here, and so let me get to him, and I'm going to let you take it away, Dr. Grant.
Well, thank you so much, Maria, and thank you everyone for being here. This is really a great opportunity. I'm so appreciative of the invitation, and I'm going to give you just some brief opening remarks. So my name is Jim Grant. I'm the Senior Vice President, Chief Medical Officer, Blue Cross Blue Shield of Michigan. By background, I'm an anesthesiologist, practiced actually in the OR for over 30 years, both in Michigan and in California. High blood pressure, also known as hypertension. It's often called the silent killer. And why is that? It's really because so many people who have hypertension are really unaware that they even have this condition. It generally develops slowly over time, and it can often be a precursor to more serious illnesses, such as heart disease. I can't tell you how many patients over my lifetime have come in for surgery, and they thought they were okay, never felt funny, and we put a blood pressure cuff on. You go to the hospital. First thing they do is take your blood pressure after they take your registration cards, and found out the blood pressure was way sky high. They didn't know it. They never felt anything. They didn't know how it could happen to them because they thought they ate healthy, and it happens. It happens, and it's something that happens even more so as we age, and we have to address it. And we have drugs that can and will address it. So that's why we're here today. We want to spread the awareness that hypertension is not only essential to heart health, but maintaining a good heart is so important to our overall health, especially as we age. I got to encourage everyone that's participating here today to really connect with your primary care doctor and develop a personal plan tailored really for you. Focus it on exercise and diet, but it will optimize your heart health. It will enable you to not only extend your longevity, but more importantly, it's going to enable you to do things that make you happy. Play with your children, your grandchildren, go biking, golfing, hiking, you name it, whatever it may be. But having a healthy heart is really going to increase the probability of being able to do those things for a lot longer than otherwise. At Blue Cross, we feel it's truly our civic responsibility to help educate everyone on getting healthy and establishing a healthy lifestyle. If you visit our website, mibluesperspectives.com, I know it's a mouthful, mibluesperspectives.com. I want to encourage you all to do it and you'll find a large number of articles and blogs and videos and podcasts and TikToks. They really aim to provide objective and current information that really everybody can consume and use to develop and sustain. And that's a key to sustain a more healthy lifestyle. There's like an amazing amount of content there focused on you, focused on your heart. And there's going to be even more coming throughout February as we coordinate with American Health Month. So really, again, I can't thank you enough for allowing me to be here today. Can't thank the American Heart Association enough for the opportunity to speak with everyone in organizing this great event. These are the types of events that are so important to spreading the word, spreading education and awareness. And I'm just so honored and happy to be a small part of the session. With that, I am going to turn it back over to Maria. Maria?
Thank you, Dr. Grant. Let me get here. I'm going to reshare my screen. Also, just as a quick reminder, if you do have any questions, please type them in the Q&A portion, and then that way we can get to them at the end. We do see a few hands raised, but this will kind of be through the Q&A portion or the chat. But now it is my pleasure to, I'm going to share my screen here to introduce our next amazing speaker and our moderator that we're going to have for our discussion here today. Sharon Gibson. She is the Vice President of Enterprise Audit of Blue Cross Blue Shield here in Michigan. I am a true fangirl because she always comes to our Go Red for Women events here in Southeast Michigan. She's on our Southeast Michigan American Heart Association board. And so I am going to spotlight her. And Sharon, I'm going to let you take it away.
Thank you, Maria. Well, I am excited to be here today, very honored to be here and to moderate the conversation. We'll get to hear from some experts today that play a role in various initiatives when it comes to the fight against uncontrolled high blood pressure. Today, we hope that you will take away some best practices on how to monitor high blood pressure, how to properly take your own or have your blood pressure read, and then some of the Heart Association's policies and best practices of implementing proper techniques when dealing with high blood pressure. I'm excited today to introduce to you our panelists here today. And I'll take a minute to note that we have two of the three that are with us. First is Dr. Nishda Serene. She has been a practicing interventional cardiologist, specializing in cardiac and vascular disease in the state of Michigan since 2012. Board certified by the American Board of Internal Medicine in interventional cardiology and internal medicine. Dr. Serene also holds board certifications in nuclear cardiology, general cardiology, and echocardiography. So welcome, Dr. Serene. All right, and then I also want to introduce our very own American Heart Association staff member who is implementing initiatives in our local community, Mallory Applewhite, Vice President of Health for the American Heart Association of Southeast Michigan. So thank you both for being here, and we'll get into the conversation. And I'd like to start with you, Dr. Serene. Can you share a bit about the basics of why people call high blood pressure the silent killer, and why it is so important not only to monitor your blood pressure, but to make sure you are measuring it properly, not only for your patients, but also for individuals like ourselves to take it on our own outside of our physician?
Thank you, Sharon. First of all, thank you for the very kind introduction. I must start by congratulating AHA and Blue Cross Blue Shield for holding webinar or something that is so critically important. You know, we know hypertension, let's start with the basics, is blood pressure more than 140/90. It affects around 1 billion of the population worldwide, almost kills 8.5 million people worldwide. That's a huge number. The big questions are, we know it's a big killer. How are we doing? What are the trends like? If you look at the 15-year period from 2004 to 2019, the deaths per 100,000 from hypertension have actually increased from 16 to 31 on an average in both men and women. The effect is slightly more in women, and that impacts me because I direct the Women Heart Program for Ascension for the state of Michigan, and women do get disproportionately affected more by hypertension. If you think about the impact it has on our lives, we lose, if you look at the years of life lost in the life of a person with diagnosis of hypertension on an average, we're talking about 9 years of your life. So that tells us that it's a big killer, and it not only causes mortality, but also leads to a lot of disability in our community. When we try to fix the problem, how can we help change those numbers? One of the important things is, who are the people who are affected the most? Age is a very, very important predictor. The risk of cardiovascular events increases almost twofold if you are less than 45 years of age at the diagnosis of hypertension. It increases by 60% if you are between 45 to 55 years of age at the time of diagnosis of hypertension. And hence, preventing it is the key early on in life. And as Dr. Grant alluded to, having a relationship with your primary care physician, making sure you are checked on a regular basis and screened for it, because the earlier you're screened, the better it is. The other important question is, why is it continuing to be a silent killer? What is it that we can do differently? And again, I'm picking this up from Dr. Grant's point and hidden diagnosis of hypertension. And there's something called occult hypertension in the medical literature, where patients come to the clinics and their blood pressure is great, but at home, unknowingly, their blood pressures may be high. Typically, this is in patients with sleep apnea. This is in patients who have other conditions that would predispose them to it. And sometimes the EKG and the echocardiogram can show it. But the most important thing is that the patients monitor their blood pressure at home on a regular basis. I think it's really important to continue to generate awareness about hypertension, because prevention is the key. And unless we do something urgently, it is going to continue to be a leading killer.
Thank you for that response. Certainly grabs my attention with some facts that I hadn't considered before. Mallory, any thoughts, any additional thoughts on that point before we go to the next question?
Yes, thank you so much. And hi, everyone. Dr. Sareed, how can you follow that up? But one thing that I do want to point out with it being a silent killer is also other outside determining factors that do affect our blood pressure, such as stress, finances, access to care. So there are a plethora of other outliers that also impact our blood pressure. So it's very important, as Dr. Serene mentioned, that you have a strong relationship with a primary care provider who is working alongside you in your health and wellness journey as you are working to manage and get your blood pressure under control. Having that connection with a physician allows you to elaborate on your current life status. I'm sure most of you on this call, when you go to your doctor, you're answering a social determinants of health questionnaire, right? Which really allows your healthcare provider to really look at the whole individual and to ensure that we are addressing your physical needs, but also your social needs as well that impact your overall physical health.
Well, I appreciate that. I'm gonna kind of I think expand on that, if you will, with this question. Are there some racial groups and communities that are more impacted by high blood pressure? And if so, why is that? And I'll punt that to Dr. Serene first, and then Mallory, if you want to respond as well.
Thank you, Sharon. I think that's a great point. And to allude to that, yes, there is racial disparity. There are two sections of hypertension where we see racial and ethnic issues being really relevant. One is in the prevalence of hypertension. We do understand from all our data that we have thus far that non-Hispanic Blacks have much higher prevalence of hypertension compared to non-Hispanic white population. We also know that Asians have a higher predisposition to hypertension. This is the people who are living with hypertension. Typically, what causes that is the socioeconomic status. We believe it could be the income, it could be a zip code, it could be just the level of education that does impact it. And that can also cause its own variation within these subgroups. The second important point is how are we doing with controlling blood pressure in these populations? And what we understand is that despite the higher prevalence among non-Hispanic Blacks, the control continues to be worse. Why is that? If we dive deeper into the reasons, and we have dealt with this in our clinical practice over years, the problem is that even the scores that we have, that physicians use to stratify patients, are based upon the values for non-Hispanic whites. We do not have enough studies in racially less represented population, whether it's Asians, it's Hispanics, it's non-Hispanic Blacks. We just don't have those data to work off to know what is it that works best in that population. And there are efforts ongoing to get more of them registered so that we can study them and understand what works best in our minority population.
Thank you for that.
Yeah, and certainly to elaborate on that, going back to social determinants of health is that cultural component, right? Different cultures value different things, and specifically we eat different things. And so how are dishes being prepared? And going back to Dr. Serene's point, education, knowledge is power. And knowledge of what you're putting into your body is so important, but also the knowledge on our providers to understand these diverse cultural patient population that we're working with, having a baseline understanding of what does that home look like? Who's cooking? What are they cooking with? What, as far as ingredients, but also utensils, what do they have access to? So it's so broad, right? It's so multi-layered when it comes to looking at diverse or that higher risk population.
Thanks for that, Mallory. I want to drill down on that a little bit with a question that may expand a bit in that space. So as you work with community organizations, folks in the community, what are some of the issues and experiences you've seen? One of the things you talked about is a cultural phenomenon. I don't know if it's a phenomenon, but a cultural I would say experience or reality of how we cook our meals. But what are some of the issues and experiences you've seen when it comes to ways that health inequities have caused members to not have proper access or resources to control their blood pressure? I think Dr. Serene talked about those two pieces of prevalence and control. But what are some of the some other health inequities that perhaps we haven't already addressed?
Yeah, so I can certainly think of one that has kind of come up across the board with some of our clinical partners is transportation. Transportation, getting folks physically to the doctor is one thing that we are finding to be a big gap in some communities. Being able to go and have those follow-up visits, going to that initial doctor's appointment, getting your baseline numbers, but then the follow-up. Usually doctors want to see you in 3 months, 3 to 6 months, even depending on where your current health status. So getting folks just to the doctor is so important. Also, we live in a world of technology, right? We are advancing day in and day out. So technology, we have found that although we are improving and making, visiting the doctor right in the comfort of your home accessible, technology has become a barrier as well. generationally, but also financially, giving folks access to internet, a cell phone, a laptop, a tablet, things of that nature. So those are some other disparities we have found that that do impact individuals' health as well as their access to care.
All right, thank you. I'm going to stick with you, Mallory, and now kind of take us back to some of the work that the American Heart Association is doing. It's known for a legacy of funding research to find best ways, best practices, and new techniques to improve the health and well-being of people in general that are affected by cardiovascular disease. Can you talk about a bit about the American Heart Association Target BP or blood pressure program, and really how they are, I would say how they're trying to work with various community organizations, and then also the type of outcomes that you're seeing with this programming?
Absolutely. So our Target BP program was established in 2015 in partnership with the American Medical Association. And it essentially was designed and developed to be a tool to help clinical partners, clinicians, providers to improve blood pressure control, as well as patients. So within the Target BP program, it is a recognition program because we certainly want to highlight and uplift the work of our community partners who are actively working to control blood pressure in the community. So we do love to highlight those clinicians, those providers who are moving the needle in a favorable direction in reducing the blood pressure in their patient population. But also the Target BP program puts some onus on the patient. We want to partner with the patient to ensure that an individual is taking an active role in their health. So we can go to the doctor and the doctor can give us a laundry list of things to do: eat better, get more rest, drink your water. But what tends to happen is we leave that visit and we just kind of go about our day. So it's very important that individuals are taking an active role in their health and controlling their blood pressure. And essentially, the Target BP program was designed to allow providers and patients to walk together to improve their overall health. What we have found with our Target BP program, in conjunction with self-monitoring blood pressure program, which is an opportunity for patients to actually take a blood pressure device home, monitor their blood pressure, and work closely with their provider, we have found some very favorable outcomes. Individuals are taking an active role in improving their blood pressure, measuring it regularly, and also working with community health workers that are associated with their clinics to be educated on their blood pressure. They have weekly conversations with community health workers that takes them through how to eat healthy, reducing sodium, getting physically active, which is so important to help manage our blood pressure. Also sleep. Sleep is so important, although I don't know how many of us are getting that recommended, but and also hydration. So there is a curriculum, if you will, that is associated with our self-monitoring blood pressure program under the Target BP.
Very good. I'm going to switch to Dr. Serene and move us to the maternal health space. And that's something that we are focusing on surely at Blue Cross and Blue Shield of Michigan. But why is it so important for those that are pregnant to pay close attention to their blood pressure and other cardiovascular diseases that tend to turn up during and even following pregnancy? And also, can you talk about any new discoveries or treatments that are being used in these spaces?
Sure. Thank you, Sharon. Maternal health is really, really important. And one of the leading causes of death continues to be hypertension. And the one thing that bothers us the most is that it is preventable. It is something we can take care of if we diagnose it early and we manage it aggressively. First, why is it important? If women develop hypertension during their pregnancy, which can be in different forms, it could be just gestational hypertension, these are medical jargons, and then there is preeclampsia if with hypertension there is some evidence of organ damage, and then there is eclampsia. But whichever form they have, it can affect the health of the fetus and it can affect the health of the mother. And both of those are critically important. It can lead to preterm labor, it can lead to growth retardation in the child, it can even lead to premature births, and it can lead to fetal demise. For the mother, it can lead to cardiovascular events up to 10 years after the first pregnancy. We don't understand quite yet as to what is the chicken and the egg situation. Is it that the women who develop hypertension during pregnancy are predisposed to it? Or is it that pregnancy is such a stressor and all the changes that occur in the body predispose women to that event? But we do understand that once they have that diagnosis, women are at two specific risks. One is the risk of developing chronic hypertension, which is higher than their cohort, comparative cohort. And the second is the risk of cardiovascular disease moving forward up to a follow-up period of 10 years that we have data on. So it's really important for women to make those little lifestyle changes, because when they are diagnosed with hypertension during pregnancy, we are limited on what we can provide them in terms of medications to treat the blood pressure. Our goals change. They are managed very differently. So if a woman has the diagnosis of hypertension during pregnancy, the first most important thing is that she should be seeing a cardiovascular specialist who can manage the blood pressure closely. While we usually want the blood pressure to be less than 130 over 80 in our patients with hypertension, in pregnancy, we want a little bit of higher blood pressure. We want it to be close to 160 over 80, because we also have to be mindful that the fetus gets the blood flow through the placenta. We cannot compromise it. So the hypertension part of it also is really important. As Mallory alluded to, regular little adjustments in their diet are really important. Exercises that are safe during pregnancy are really important. And one of the things, Mallory, we have seen in our practice is that having online community classes has been very useful, especially in this day and age where travel can be an issue, especially for the people who are more affected and less well controlled. Travel, especially during pregnancy, travel can be an issue for women. So we have online community classes that have been very useful, making little adjustments in their food. For instance, if you're using oil, just replace it with olive oil. It's not that big of a change. If you're eating white rice, just replace it with quinoa or brown rice. So it's minor adjustments that you make every day that go a long way. If you like pasta, replace it with lentil pasta or with brown pasta. So these little adjustments I find have been very, very useful, especially in pregnant women where our medical treatment is very limited. There are medications that are out there that are being evaluated for hypertension management, but we do wait for the actual robust data before we start prescribing it to our patients. There is something called cardiomyopathy, which is one of the biggest killers of women during pregnancy. And when you have that cardiomyopathy, one of the newer evolving treatments for that is bromocriptine. But that, again, is something we are not using. It is a very investigational stage. What I think works the best in my women who have maternal hypertension is lifestyle changes, as Mallory alluded to, eating healthy, cardiovascular health prior to pregnancy. And I'm seeing a lot of questions come up about genetic component. And yes, there is a genetic component to it as well. And there is an ongoing study called the Masala study, which is actually looking at the genetic predisposition, particularly in our in the ethnicities that are less well represented and our minorities. So we have more data coming out. We have a lot of trust. As of now, the most important take-home point for pregnant women is check your blood pressures at home. It's really important. If your diastolic blood pressure, not the top number, but the lower number is more than 90, that is the strongest predictor of adverse outcomes. Please make sure you see physicians regularly. Make sure you make the little lifestyle adjustments. They go a long way. The strongest predictor of decrease in blood pressure is not a medication. It is lifestyle change. So it's really important you stick to that.
Thank you. That is super informative, especially coming from somebody who a few years ago experienced with my niece preeclampsia, and the idea that you, or actually, and post, but the idea that you moved through that and you've survived through that challenge. But you talk about a tail that's up to 10 years long, that I'm not sure that that we're all aware of. So I appreciate that perspective and something to think about. I want to shift to you, Mallory, and ask about what the Heart Association is doing relative to research and programming geared towards high blood pressure and maternal health.
Yeah, so I think today's theme is knowledge. Knowledge is power. I will say it again. And to Dr. Serene's point, we need research. Research is so important for us to be able to discover what are the gaps, what needs to change. We know that there is systemic racism in our healthcare system. We know that there are health disparities. So we need to understand what is the underlying root of that? How can we make changes? But the only way we can get there is through research. The AHA has committed $20 million to just that. $20 million has been committed to our Health Equity Research Network, or HERN, which is essentially an opportunity for researchers to research maternal health and those health disparities. We currently have 5 research programs going on right now that range from educating clinicians on cultural diversity, postpartum mental health among maternal or birthing persons, if you will. Trying to think, as you can imagine, they're very long names, these research titles, but also around technology and as it relates to maternal health. So the AHA is working quite aggressively, if you will, to help close these gaps and get these questions answered.
Thank you for that. And I will shift the question to more broadly than maternal health, but as it relates to high blood pressure and the Target BP program, what are some of the ways that you're seeing some of our community partners incorporate the program and help us to reach out and engage with even their patients and to make sure that they're following the program?
Yes. So it is so important that we are getting out into the community. And so one thing that the AHA has been working on, especially here locally in the Detroit area, is what we call our community clinical linkages. So we want to connect our clinical partners to our community partners. And we're doing that through community blood pressure screen and refer opportunities. So we have community partners where they are actually actively going out into their community and doing blood pressure demonstrations. They're educating individuals on the proper placement of their cuff. What do their numbers mean? And broadly just educating them on the importance of eating healthy, staying active, drinking your water. But most importantly, getting them connected to a clinical provider if they do not currently have a PCP of their own. And so our community partners are working alongside our clinical partners to bridge that gap, if you will, and going back to that access to care, being able to come to your local library. We have these blood pressure screen and refers at local libraries. If you can come in and get your blood pressure checked, understand something may be a little off. What do I do next? Being able to have that information readily available is so important. Having that contact number, the hours of your local clinical partner is so beneficial to community members. And so, yeah, we are seeing a huge, what can I say, excitement around this community and clinical linkage and helping individuals to know their numbers as well as manage any uncontrolled blood pressure.
Great, thank you for that. I think we've gotten through the bulk of our questions for the day. I do have one final question before we open it up to the Q&A and any closing comments that you have around the dialogue we've had thus far. But I will say, I'll start with Dr. Serene, and then we'll go to Mallory to give Mallory a minute to catch her breath. This has all been very eye-opening, and I've been making some notes as well, and a good reminder to us all, whether we're patients or part of a medical staff or with facilities or community organization that we're working with, we all need to make sure that we're tracking and monitoring and controlling our blood pressure. So I just want to know if there is any closing comment anything that you want to leave this group with before we get into the Q&A?
Thank you, Sharon. That was great, Mallory, and congratulations on doing such great work. I mean, the best way of reaching people is going into the community and getting to them, especially when the prevalence is so high. The one rule of thumb that I tell all my hypertensive patients, or in fact, all my patients who are at risk of hypertension, is to remember a triangle. And the triangle is one, what you're eating. It's really important what you put on your plate. And we alluded to, it's got to be as colorful as possible. When you're looking at the colors, you want more vegetables compared to fruits. Vegetables are healthier. And if you're looking at fruits, you can Google glycemic index for whichever fruit you're eating, eat the one with less glycemic index. The second part of the triangle is your exercising. We know our guidelines are 30 minutes, 5 days a week. You can do it the way you like. It doesn't have to be 30 minutes in a day. It could be 10 minutes increments, as long as it's 150 minutes over the course of 1 week. So if I have to work out, I only have time because I have kids and I'm busy, or if I'm working long hours, I 10 minutes, do the 10 minutes that day. It adds up. And then you can do additional 10 minutes, 150 minutes a week is the key. Plus, exercising only counts when you cannot speak in full sentences. So it has to be moderate exercising. The clock starts when you start exercising and you cannot speak in full sentences, and the clock ends when that ability to speak in full sentences ends. So there has to be moderate intensity for 30 minutes a day for 5 days a week. The third part of the triangle is know your statistics. No condition in our community runs alone. There are brothers and sisters that work with it. Diabetes, hypertension, stroke, all of these are connected, intertwined. The numbers that you need to be very careful about are your waist circumference. It has to be less than 40 inches in men and 35 inches in women. And that helps tell us about the visceral fat that we have, which also increases the risk of hypertension, atrial fibrillation, stroke, heart disease. Know your blood sugar, make sure you're screened for diabetes. If you have family history, you may have a good relationship with your primary care physician. That's my 2 cents. It was great. Thank you for having me on this panel.
Awesome. Mallory?
Thank you. Thank you. You know, my rule of thumb, or what I want to share with everyone on the call, is to speak up. Speak up. You are the best advocate for your health. And so when you have time with a provider, with your doctor, take up that time. You are there to ask questions, be a child, be inquisitive. There is no dumb question when it comes to your health. Speak up. If you feel weird, if anything feels off, ask questions, probe and probe and probe until you are heard. That's the one thing that I do want to leave everyone here with this call, is to just speak up, advocate for your health, be inquisitive, be curious.
All right. I am going to take a minute and run through some of the questions that have come up in the chat. One is, let's see here. We've covered it, but we should make sure we touch it. How does stress impact high blood pressure? And either of you can take the question.
I can take that if that's okay. So yes, stress is definitely predisposes to hypertension, and it gets a little bit technical when we talk about it, because stress can cause something called endothelial dysfunction, which affects the cardiovascular health at its most cellular level. It is not just with the hormones in the body; it's got to do with affected cell levels. We know that stress can also cause heart failure. It can cause your heart function to go as low as 30%. That's called the broken heart syndrome, or Takotsubo's. So yes, stress can cause hypertension. The more important question at that point is that hypertension sustained, or does it get better? And does it need to be treated? And how it needs to be treated. Again, one of the important things is keeping your blood pressure machine at home, monitoring your blood pressure on a regular basis, and of course, keeping the stress levels down.
All right. And then the next question, or it's actually looks like a set of questions around monitoring at home. Is it possible to order a blood pressure cuff to be able to self-monitor at home?
So one rule of thumb that I do want to mention when it comes to self-monitoring our blood pressure is a very important number. And while we can measure our blood pressure at home, it is so important that you are doing that alongside a provider. So yes, you can order blood pressure because you can even get them at CVS, but the most important component of that is to work with a provider, because if you have a number or a reading that may be off. And one other note that I want to make, our blood pressure ranges throughout the day. Morning, from afternoon to evening, our blood pressure can fluctuate. So it's also very important to work with the provider as you're monitoring your blood pressure, that you're on a cadence to ensure that you're getting valuable numbers, I should say, for lack of better terms, more accurate data. But yes, a blood pressure device can be purchased at a CVS or online, if you will. But it's very important that you are working with a healthcare provider as you are measuring your blood pressure at home.
Can I just add one quick, Mallory? That's a great point. I just want to add something real quick to that. And one of the things I encourage everybody to do is that when you have that blood pressure machine, is to carry that machine to every physician visit every time. A lot of times what we've seen is that the machine is not well calibrated. Your home blood pressure machine may not actually be reliable. And patients have questions, I'm putting it on my wrist, is it giving me a good value? Sometimes that's the only option they have. But again, if it's calibrated to our machine as there's less than 20 millimeter mercury difference, yes, that's okay. The other quick thing is about the blood pressure checks at home. As Mallory alluded, it changes all day. It's very useful for the physician if you keep a diary, and I call it the BP diary, and you write down your numbers, different days, different times, as random as possible. It really helps a physician understand. A lot of times, the hypertension medication only needs to be timed correctly and not really discontinued or increased. So it really helps if you maintain that diary.
Mm-hmm.
Great answers. Another question here, I think will help with that awareness piece is, does aging itself create greater hypertension? And I think we touched on this earlier in terms of where our risk levels are, but this question is just the aging itself create greater hypertension?
Yes, it can. And the reason for that is that as all of us age, we do have calcification in the arteries. There is stiffening that happens in the arteries. And there are two kinds of blood pressures. There's systolic and there is diastolic. And when aging is purely the reason for it, diastolic is the one that tends to go up because the arteries are so stiff, they can't relax. But again, yes, to answer that question, with age, that can happen. And if it happens, the earlier it happens, that tells you about your cellular aging. And that is why we worry. If it happens earlier, the process, that could point towards a more significant risk of heart disease because your body is aging quicker than it's anticipated to.
Wow, that's great insight. And a great perspective to have, because oftentimes when we're younger, we think we're invincible.
That's true.
Your response says it's a marker for us as to where our body really is. One other question here, and I'm reading this and I think about something that I typically will say to my doctor, which is, I don't want to be treated, I want to be healed. And this question is, once you start blood pressure medication, will you ever be able to stop taking it? And I know the answer to that has been woven into the responses that I've heard so far, but we'll take the question directly. And we'll start with you, Dr. Serene.
Well, thank you. Thank you, Sharon. Yes, answer is yes. And I've had patients who've been off medication. Typically, what it boils down to is numbers, right? This is objective data. We are trying to achieve a systolic blood pressure of 120, preferably 115. And if your blood pressure is, say, 138, and you're on a baby dose of amlodipine, 2.5 milligrams, we know that if you were to lose weight, your blood pressure can come down, but even 5 pounds, your blood pressure will come down 20 points. So yes, if you think about it objectively, there is, if you decrease the salt intake and you lose that weight, your blood pressure will come down 20 points. And when it comes down, then yes, you will be off that blood pressure pill. And we have seen patients, it doesn't happen very often because it's much easier said than done. Let's be honest about it. You know, when it's much easier said than lose weight, but when it's real life, it gets tough. And just with dietary changes, with exercise and weight loss, I've had patients who've been off blood pressure medications. But we need to monitor them very closely because we want to make sure, especially with the BP diary, to make sure that the blood pressure doesn't start to go up again.
Thank you for that. And that response really, I think, gets to some of the accountability that Mallory talked about with some of the programs, is how do we take accountability to manage our own health and the things that we can do to cause this to be a story to tell that we're not living anymore, right? All right.
That's true.
One more question or another question. And it is, for patients with sleep apnea, how much of a difference in blood pressure is expected when they're compliant with their CPAP usage?
That's a great question. And honestly, I don't have an answer to that. And that's because I don't have data for it. And everybody's sleep apnea is very different. People are diagnosed at different levels of sleep apnea based upon what your EKG looks like or your echo looks like. We have something called diastolic dysfunction on echo that we see in a valve that's regurgitant, and we see pulmonary pressures. And so there are two, it's a paradigm. It's not a one-time diagnosis. It starts and then it gradually becomes a more permanent condition. If you have sleep apnea, there are two major issues that can happen. One is hypertension, and the second is atrial fibrillation. You're predisposed to both. So it's really important to be compliant with the machine. And in all honesty, every patient is built differently when it comes to sleep apnea. Have I personally had a patient who has had blood pressure control with sleep machine use? Yes. And typically these are women who present in their 30s or 40s. They're younger women who've suddenly been diagnosed with hypertension of 180, 190 on an office visit or a hospital visit and have never had it. That's a typical presentation of sleep apnea patient. And if they're early in the cycle, yes, you can see some response. But if they're late in the cycle, then you don't.
Okay, thank you for that. I'm going to direct this next question to Mallory and Dr. Serene. If you want to add anything, you can from your perspective. This question gets to resources. And the question is, are there any resources available to individuals that can't afford blood pressure cuffs and supplies? The question comes from a social worker, and they often get consulted for supplies and for members that can't necessarily afford those items. So any resources they can direct folks to?
Yes, absolutely. So certainly if you have some type of health insurance, health coverage, usually if you are diagnosed with hypertension, you will qualify or could qualify for a device at no cost. So if you are working with a provider, you've been diagnosed, ask your PCP if they can put an order in or write a script for you to receive a device. Also, we part of AHA, we have a whole leg of policy work through our advocacy branch. And with that, we are through Medicaid. Medicaid came out with a bulletin where if you are a Medicaid eligible patient or individual who has also been diagnosed with hypertension, you can access or have access to a blood pressure device. So there are several resources where you can get a device at no cost or minimal cost. But again, partnering with a healthcare provider is the best way to go about doing that.
I think Mallory covered most of it. I just have one thing that I do in my clinical practice, Mallory. If a patient doesn't have, insurance and they don't have a diagnosis of hypertension that makes them eligible for coverage for the machine, I do ask them to just walk into CVS like one day a week On their way back home, different times, different days, they have a machine sitting there. Put your hand in, just get a quick number, write it down for me. And I ask them to wait a few minutes before they do that. So that's one of the resources that is also available free of cost. And I think if we can have more of these blood pressure machines set up at all these, grocery stores, it's going to be a huge accomplishment to help these patients out.
I appreciate that, Dr. Serene. I know we have a campaign at the Heart Association around It Takes a City. And one of the things that we've talked about around that is making sure that we have these resources where people live and breathe, and not having to walk outside of their normal route for the day, but where you shop, where you get your hair done, those types of things. So I appreciate that. And looking for those things, I've been pleasantly surprised to walk in a grocery store and see that, and or some other store where I was not expecting to. I'm like, let me see if this works. I'm gonna put my arm in here and check it out. And
Yeah.
certainly we have them throughout our facilities in various buildings that we can leverage here at Blue Cross. So I think Maria, I think I've reached the end of your questions. I did see one last question that I did want to ask. Not sure if we have a response for it, but it certainly piques my curiosity because of a personal experience with my family. And Dr. Serene, this may be for you. And the question is, what do we think the leading cause of postpartum preeclampsia is? And the person asked the question, are we still at risk for the 10 years? And I think you said that for developing hypertension, yes. But in your experience, what do you think the leading cause of that is?
So preeclampsia, eclampsia, hypertension. So there are two terms I want to clarify before I answer that. One is cause, and the other is predisposition. Cause, when I say something causes something, you have to have an association, and you have to have data to tell you when this is there, this issue is there, eclampsia will happen. But we don't have those data. So cause itself, we're still investigating it. We don't know if these patients have genetic predisposition because of which they develop hypertension during pregnancy, or they have predisposed diabetes, hypertension, genetic, which actually causes the stress of pregnancy to trickle it in. Or is it the weight gain that they get during pregnancy and the escalation in that weight gain that changes that metabolism in the body and causes preeclampsia? But I can tell you with fair confidence what are the predictors, what increases the likelihood of preeclampsia. Younger age of the first pregnancy, multiparity, having multiple children, specifically more than 3 children, having premature delivery, if you've had it before, or premature child, also increases the risk. Of course, if you have hypertension, that increases the risk. African American community, are women of color are at higher risk as well. So if you have, plus in a stressful job, if you have a stressful job, that also increases the risk. So having any of these or multiple of these, and frankly, we have scoring systems where the more you have, more of these that you tick boxes at, the higher the risk.
Thank you for that. I appreciate that. And it certainly seems to be more prevalent. I don't know if it is or if it isn't. I'm just more exposed to it. So I appreciate the perspective. And I do think we've reached the end of our Q&A period. Certainly appreciative of your expertise and sharing your perspective with us to drive awareness. And I would expect for this group dialogue, so the conversation not stopping here, but to continue on so that we can not only be aware but take necessary action. So Maria, I'll turn it back to you. And again, thanks to the panel for their time today.
Yes, thank you all so much. Your conversation has been so insightful, and I truly appreciate you all. Thank you, Sharon. You've been a great moderator and kind of fielding the questions. And thank you, Dr. Serene and Mallory. honestly, your information is, I mean, I work at the American Heart Association, but I've learned so much. So I am truly, truly grateful for all of you. We do have one quick little video to close us out in. I also want to say thank you to Dr. Grant as well. And again, to Blue Cross Blue Shield of Michigan. We wouldn't have this conversation put together without them. So we are truly grateful. I'm going to close it out with the video, and then we will be sending out this recording so you can share it with your family, friends, coworkers, or reference back to it. But thank you all again, and I'm going to get the video going, and then I hope you all have a great rest of your day. I'm going to press play.
Okay, let's have a real talk about blood pressure. Do you monitor yours regularly? It's something everyone with high blood pressure should do, but it's something most people don't know how to do correctly. Checking your blood pressure regularly will help let you know if you have it under control. It will also help you start to understand which factors are putting you at high risk for stroke and heart attack. Before I get to that though, I just want to stress one thing. If you have high blood pressure, you should talk to your doctor to figure out how frequently you should be checking it at home. For most people, taking your blood pressure twice in the morning and twice in the evening, even just for a week, will help you and your doctor get a better understanding of your blood pressure. For morning readings, it's best to take those before you take your blood pressure medication. It's also very important to avoid exercise, caffeine, or tobacco at least 30 minutes prior to testing, since those can affect your levels. Now, let's move on to talk about the proper way to measure your blood pressure at home. Nearly half adults in the U.S. have high blood pressure and are at high risk for stroke and heart attack. So self-measuring is one of the easiest ways to be proactive about our health. Here I have my blood pressure monitoring device. It's easy to use and it helps me get an accurate reading. Be sure to get an automated device with the upper arm cuff. That's the type doctors recommend. The first thing you want to do is find a quiet place to sit where your back is in an upright, stable position. A dining room chair is great. You want to make sure the chair isn't too soft so your body is fully supported. Sit with your feet flat on the floor and don't cross your legs or ankles. If you need to use the bathroom, make sure you go before you do your reading. Next, rest your arm on a flat surface with your palm facing up. Place the blood pressure cuff on your bare upper arm just above your elbow. Your arm should be relaxed and resting so the cuff is at the same height as your heart. Now rest quietly for 5 minutes before taking the first measurement. Avoid talking while taking your blood pressure measurement. Once your first measurement is completed, write down the blood pressure numbers and pulse that are displayed on the device. Wait 1 minute and then repeat this process again. As you just saw, it's important to check your two measurements at around the same time each morning and evening. At your next doctor's visit, be sure to share your blood pressure numbers so you can discuss the numbers and so your care plan can be changed if necessary. That's it. Not bad, right? Measuring your blood pressure at home is easy to do and a great way to stay on top of your health. If you have more questions about managing or measuring your blood pressure overall, visit the website.
Thank you all so much again, and I hope you enjoy the rest of your day. And as I mentioned, we will be sending out this recording for you all to have. And so thank you all so much. Have a great day.